It's the 11th video in my series about fluids, electrolytes, and acid-base disturbance. In the previous video, we talked about the difference between osmolality and tonicity, so make sure to watch that video first. Today, we'll talk about isotonic, hypotonic, and hypertonic disorders because students lose their minds over these topics. It's going to be a long video, so let's get started. Some words of wisdom. Whether you think you can or you can't, either way, you're right. It's all in your mind, folks. It's all in your mind. Let me answer the question of the previous quiz. Which of the following scenarios do you expect to find in a male smoker for 40 years with a lung tumor? So, you are in your exam and you're thinking, I have a male smoker for 40 years with lung tumor. I bet it's malignant. It's asking me about ADH level and plasma osmolality, so I'm thinking maybe SIADH because it's related to small cell lung cancer. Yes. Does that mean that every smoker with lung cancer is going to have SIADH? No, but on your exam, they will. You have to make generalization because without generalization, there is no wisdom. These folks are deep. Cool. So, in SIADH, what's going to happen to the plasma ADH level? It's called the syndrome of inappropriate ADH. There is lots of ADH in the plasma, which makes A incorrect because A is low level of plasma ADH and C is incorrect because again there is low level of plasma ADH. Use the x-axis. So it has to be either B or D. Brilliant. When ADH increases, it's gonna increase pure water reabsorption. If you remember your silver equation, you have the total body sodium over the total body water, and they happen to equal the serum sodium concentration. Very cool. The increased ADH is gonna cause water reabsorption, which will lead to decreased serum sodium concentration. Decreased serum sodium concentration is gonna decrease the plasma osmolality. So B is not correct, D is correct. I have low plasma osmolality and I have high serum ADH level. Cell membrane transported is either passive or active. Osmosis is passive. Osmosis is movement of water from high concentration of water to low concentration of water, or from low concentration of solute to high concentration of solute. We have talked about measured osmolality and calculated osmolality in a previous video, as well as the osmolar gap, which is the difference between the two. And effective osmolality does not include urea. It includes sodium, which is the king, and glucose. Osmolality is the number of osmoles in a solution counted by this stupid osmometer, but tonicity only counts the effective osmoles and a described osmolality relative to the plasma. Therefore, we have three types of solutions: hypotonic, isotonic, and hypertonic. The normal tonicity of the plasma is between 275 and 295. Less than 275 is hypotonic, more than 295 is hypertonic. What is the main contributor to serum osmolality and ECF tonicity? Answer: sodium. What is the second most important? Answer: glucose. When you have more serum sodium, this is called hypertonicity. Your body will try to retain water in order to compensate, so ADH is stimulated. The main stimulant for ADH is hypertonicity, as we have discussed in the last video. On the other hand, if you have less serum sodium, this will lead to hypotonicity. ADH is inhibited because the body will try to lose water in order to compensate. When you lose water, your tonicity is gonna go up and back to normal. Don't ever forget the silver equation. Serum sodium equals total body sodium over total body water. We have 9 fluid disorders and we're gonna classify them into 3 broad categories: isotonic fluid disorders, hypotonic fluid disorders, and hypertonic fluid disorders. Isotonic fluid disorders just means that the tonicity of your plasma is normal. It's around 290. Hypotonic means the plasma osmolality is low. Hypertonic means the plasma osmolality is high. In order to try to figure out each of these disorders, we have to use the two-step approach. Step 1, use the silver equation. Step 2, use your brain to figure out the direction of the osmotic gradient from ECF to ICF or from ICF to ECF or neither. Rules of thumb. Either you have isotonic loss or isotonic gain of fluid, which means you are losing an equal amount of salt and water or gaining an equal amount of salt and water. There is no change to the serum sodium. Let's say you have an isotonic loss. Okay, decrease total body sodium, decrease total body water, serum sodium is not going to change. So there is no change in serum osmolality because the main contributor to serum osmolality was serum sodium. If serum sodium is normal, there is no change in osmolality, so there is no osmotic gradient, there is no water shift, so there is no change in the ICF compartment. Water is not going to flow out or into the ICF compartment. Only the ECF, which is outside, is going to change. If you gain an isotonic fluid, ECF is going to expand, leading to symptoms of ECF volume overload. If isotonic loss of fluid, which means you lost an equal amount of salt and water, the ECF compartment is going to contract and the ECF volume depletion will occur, leading to signs and symptoms of ECF volume depletion. So let's start with the first problem. Isotonic loss of fluid, which means loss of an isotonic fluid. We lost an equal amount of salt and water. Let's do this on the silver equation, which is the first step. Decrease total body sodium, decrease total body water. What's going to happen to serum sodium? Normal. It's called normonatremia. But we lost fluid. What's going to happen to the ECF, you stupid idiot? It's gonna contract, decrease ECF volume, leading to extracellular fluid volume depletion. What happened to the serum sodium? Normonatremia didn't change, so it's normal. What will happen to the serum osmolality when the serum sodium is normal? The answer is normal. What will happen to the ICF? Now, the second step is to use your brain. If the serum sodium is normal and the serum osmolality is normal, is there any osmotic gradient? No. Is there any water movement? No. So the ICF is going to stay the same, so no change to the ICF volume. Example of cases when you lose an isotonic fluid. How about hemorrhage? If the plasma is the ultimate isotonic thing, if you lose blood in cases of hemorrhage, of course you're losing an isotonic fluid. How about secretory adult diarrhea in cases of cholera? You're losing an isotonic fluid, an equal amount of salt and water. How about GI bleed? So let's represent this on the stupid graph. ECF contracts. Serum osmolality didn't change, so don't change the y-axis. ICF, no change. Boom. Clinically speaking, you have signs of extracellular fluid volume depletion. Dry skin and mucous membrane? Sure, you lost an equal amount of sodium and water. How about decreased skin turgor? If total body sodium is decreased, skin turgor is decreasing. Positive TIL test, yes, orthostatic hypotension. If severe enough, you can have signs of shock. Symptoms, if the patient is thirsty, yeah, we are losing fluid. Extracellular fluid volume depletion is a stimulant for thirst sensation. Dry skin, dirt in my eyes. Why? There is less tears in your eyes. We lost fluid, baby. Decreased urine volume. Dizzy when I stand up, yeah, same thing as orthostatic hypotension and constipation because there's less water. How to see this on the lab? You have high hematocrit. Why? Because we have less water now. Very nice. How to treat this? IV normal saline. Give the patient what they lost. If they lost an isotonic fluid, give them an isotonic fluid. Second scenario, isotonic gain of fluid. We gained an equal amount of salt and water. Let's use the silver equation. We gained total body sodium, we gained total body water. What's going to happen to serum sodium? No change. What's going to happen to the ECF when you gain a fluid? The answer is it's going to expand, leading to extracellular fluid volume overload. And the serum sodium is normal, therefore serum osmolality is normal. The ICF, use your brain. Serum sodium is normal and osmolality is normal, there is no osmotic shift, so no change. Examples in the clinical world: excessive administration of normal saline, like your nurse was sleeping or your doctor was an idiot. Instead of giving you like 2 bags of normal saline, they gave you like 10. We gained an isotonic fluid, increased total body sodium, increased total body water, normal serum sodium, normal serum osmolality. Now, normal serum osmolality, leave the y-axis alone. ECF expands, please expand the ECF and leave the ICF alone. Signs and symptoms. We have signs of ECF volume overload, such as dependent pitting edema because of increased total body sodium. We have cavity effusion, such as ascites, pleural effusion. Increased body weight. The most common cause of increased body weight in a hospitalized patient is increased total body sodium. Increased blood pressure. We are gaining fluid, you idiot. Symptoms, the patient will say, I have swelling, bloating, cramping, and headache. Lots of fluid. I have shortness of breath. Why? Pleural effusion. I have racing heartbeats. Increase urine volume. Yeah, because you have lots of volume. How to treat this? If the problem is gaining an isotonic fluid or gaining salt and water, so the treatment is use your dead gum brain, restrict salt, restrict water. You can use diuretics if you wish. Now we are done with the isotonic disorders. Let's go to the hypotonic fluid disorders. So let's have some rules on the table. It's a hypotonic disorder, therefore the plasma osmolality is low. That's the definition of a hypotonic. What is the cause of low plasma osmolality? Serum sodium is low. It cannot be glucose, remember? You have glucose over 18. Let's say that you have severe hypoglycemia and I'll give you 20. 20 over 20 is 1. When your osmolality decreases from 5 to 1, it's not a big deal. Hypoglycemia will never lead to hypotonicity in a million years. So the osmotic gradient is there, yes, because the ECF osmolality is low. Water is going to flow from the ECF to ICF because ICF now is more concentrated. ICF is going to expand. The cell is going to swell. If this is your brain, you'll get mental status abnormalities. Hypertonic loss of sodium will lead to loss of greater amount of sodium than water. Let's use the silver equation. We lost sodium than water. What will happen to the serum sodium is going to be low. This is called hyponatremia. What will happen to the ECF when you lose a fluid? It's going to contract. ECF volume depletion. Serum sodium decreased. Serum osmolality, of course, decreased. ICF, use your brain. Now let's draw this. We lost a hypertonic fluid. We lost more sodium than water. So let's draw the sodium, only 1, and let's draw the water, 2. We lost more sodium than water. Now the cell suddenly appears to be more concentrated. Water is going to flow into the cell. The ICF compartment is going to expand. Example in the real life, diuretics, because remember when you give a patient diuretic, this was a quiz question, you lose more sodium than water. How about Addison's disease? Same thing. 21 hydroxylase deficiency, same thing. Let's use the stupid graphs. You lost a hypertonic fluid. Okay, so ECF is going to contract when you lose a fluid. Don't be an idiot. Serum osmolality is going to decrease because of decreased serum sodium. ICF is going to increase when you use your brain to determine the direction of osmosis. So please decrease the serum osmolality for me. Decrease the y-axis from here to here. Please contract the ECF, okay, and expand the ICF, okay. Clinically, you have the signs of extracellular fluid volume depletion and you have mental status abnormalities because of sodium problems. Symptoms are the same, plus confusion and drowsiness because of hyponatremia. Lab, increased hematocrit and increased serum concentration of other ions because you lost the fluid, so it's as if we have more potassium and calcium now. How to treat this? Okay, we lost a hypertonic fluid. A stupid student will say, give them a hypertonic fluid. An idiot. We rarely use hypertonic saline in the hospital. Rarely. Give the isotonic. It's better, it's cheaper, it's everywhere, and it's better for the patient. And it's easier on the hospital's accounting department. Next, when you gain a pure water, let's use the silver equation. Gain pure water. What's going to happen to the serum sodium? It's going to decrease, so you have hyponatremia. What's going to happen to the ECF when you gain something? it expands, but it's a mild expansion. Why? Because what determines the ECF volume status is the total body sodium status. And here the total body sodium status didn't change. That's why we call it euvolemic hyponatremia. I know that the ECF volume expanded a little bit, but for the sake of argument, we call it euvolemic because the total body sodium didn't change. What determines the serum sodium concentration is the total body water status, as I've told you before. Hyponatremia and hypernatremia are usually due to water problems, not sodium problem. Serum sodium, decrease hyponatremia. Serum osmolality, decrease. How about the ICF? Use your brain. When you gain pure water and you have the same amount of sodium, okay, now the sodium outside is diluted. The intracellular fluid suddenly appears more attractive to water because it's more concentrated, so the ICF compartment is gonna expand. Example please, syndrome of inappropriate ADH. ADH absorbs free water from the kidney tubules, reabsorption of water, leading to hyponatremia. This is a euvolemic hyponatremia. You will never get edema because the total body sodium is normal. How about psychogenic polydipsia? When you keep drinking like tons of water, you will end up with a euvolemic hyponatremia and you can get mental status abnormalities. So let's use the stupid graph. We gained pure water. What will happen to the ECF? Expand, so please expand it a little bit. Serum osmolality is gonna drop because serum sodium decrease. Let's decrease it. And ICF is gonna expand. Please expand it. Okay, signs. You have normal skin turgor. Why? Total body sodium is normal. No pitting edema. Why? Total body sodium is normal. Okay, in the lab, you have serum ADH level is going to be high in cases of SIADH, but it's going to be not high in case of psychogenic polydipsia. Treatment, restrict water. Hypotonic gain of sodium. We gained more water than sodium. Let's use the silver equation. Let's gain more water than sodium. What's going to happen to the serum sodium? It's going to decrease. What will happen to the ECF when you gain a fluid? It's going to expand, leading to extracellular fluid volume overload. How about the serum sodium low, serum osmolality low? ICF, use your brain. You gained more water than sodium. Okay, 1, 2, 3, 4. Now suddenly this is hypotonic and the ICF appears more attractive to water. ICF is gonna expand. Example, the overload states, the edema states, cirrhotic, nephrotic, and CHF, we call them hypervolemic hyponatremia. Let's use the stupid graph. ECF expands, please expand it. Serum osmolality decreased, ICF expands. Always start with the y-axis, it's easier for you. Clinically, you have the signs of volume overload. How about mental status abnormalities because of the hyponatremia? Absolutely. Symptoms, we said them before. You will find high ANP and BNP if you have CHF. Albumin could be low in case of cirrhosis or you have proteinemia and nephrotic syndrome. Treatment, if you gain salt and water, restrict salt and water. Medicine is easy, folks. So we are done with the isotonic disorders. We are done with the hypotonic disorders. Let's talk about the hypertonic disorders and let's get out of here. Hypertonic fluid disorders. It's either due to hypernatremia or hyperglycemia, because if you have uncontrolled diabetes, the glucose level could be 600, 900, and suddenly instead of contributing 5 milliosmoles to your plasma, it's going to contribute 30, 40 milliosmoles, so it's going to be huge. If you have a hypertonic disorder, by definition, the plasma osmolality is high. Why is that? Could be due to serum sodium is high or serum glucose is high. Either way, we have an osmotic gradient that's going to pull water outside of the cell. The ICF is going to contract. If this is your brain neurons are going to shrink, leading to mental status abnormalities. That's why we have hyperglycemic coma. Hypotonic loss of sodium, which means we lost more water, hypotonic loss, than sodium. Let's lose more water than sodium. What's going to happen to the serum sodium? It's going to decrease. We call this, increase. I'm a stupid idiot. Sorry, increase. It's called hypernatremia. Cool, but we lost the fluid, hypovolemic. So ECF is going to contract, extracellular volume, depletion. Serum sodium is going to increase, serum osmolality high. ICF Again, use your brain. We lost a hypotonic fluid. So we lost more water than we lost sodium. Okay. Suddenly, the ECF is more attractive for osmosis. Water is going to flow outside of the cell. The cell is going to shrink. Example in real life, sweating. When you lose sweating, you're basically losing lots of water and little amount of salt, so it's a hypotonic loss of fluid. How about osmotic diarrhea? Yep, when you use laxative, for example. Osmotic diuresis in case of hyperglycemia, or mannitol in the urine. Same thing. Vomiting, you're losing a hypotonic fluid. Infant diarrhea. Yep, hypotonic. Let's use the stupid graph. Serum osmolality increased due to hypernatremia, increased the y-axis. ECF contracted because we lost the fluid. ICF contracted because water is flowing out. Contract them and we're done. Clinically, ECF volume depletion signs plus mental status abnormalities due to hypernatremia. Okay, how about the treatment? When you lose a hypotonic fluid, okay, some people will say, give them a hypotonic fluid. Okay, but we have to start with an isotonic fluid to maintain the blood pressure. Once we maintain the blood pressure, we can switch to the hypotonic fluid as you wish. How about loss of pure water? Let's lose pure water. What's going to happen to the serum sodium? Increase. We call this hypernatremia. Some people will say ECF volume is going to contract, which is partially true. It's going to mildly contract. But once you lose water and now the ECF has more solute, water is going to flow out and it's going to maintain the ECF volume a little bit. So yeah, I agree, contracts but mildly. Serum sodium is going to be high. Serum osmolality is going to be high. ECF is going to contract. Example, diabetes insipidus or insensible water loss in cases of fever. You're losing pure water. Let's use the stupid graph. Please increase the serum osmolality, decrease the ECF, decrease the ICF. How about the skin turgor? It's going to be normal because the total body sodium is normal when you lose pure water. Don't be an idiot. Very nice. How about the treatment? When you lose pure water, give water. Replace the water and try to cure the underlying condition. Hypertonic gain of sodium. We gained more sodium than water. What's going to happen to the serum sodium is going to be increased. ECF expands. ECF volume overload. Serum sodium increase. Serum osmolality increase. ICF, use your brain. When you gain a hypertonic fluid, suddenly the ECF has more tonicity and osmolality. It's going to pull water outside of the cell. The cell is going to shrink. ICF contraction. Examples: when you infuse sodium bicarbonate, when you infuse a hypertonic saline such as an idiot, some antibiotics contain sodium, and excessive stable salt ingestion. I don't know why will you do this. Let's use this stupid graph. So decrease the osmolality and decrease the ECF volume and the ICF volume. Very good. So how to treat this? If you gained through infusion, stop the infusion. The last disorder, hyperglycemia. As you know, glucose is osmotically active. It causes osmotic diuresis. When you have lots of glucose in the plasma, it's going to pull water outside of the cell. So we know that the ICF is going to contract. How about the ECF? It's going to contract. Why? Because, yeah, it's true that glucose will shift fluid like this, but will also shift fluid into the urine. It's osmotically active. We are basically losing a hypotonic fluid, and it's true that we lose sodium in urine with glucose. How about serum sodium? Now, this is tricky. We used to have sodium here, but when we have lots of glucose here, water is flowing outside of the cell, diluting all of the sodium, causing dilutional hyponatremia. Serum sodium is going to decrease. I'm not convinced yet. Okay, osmotic diuresis in the kidney makes you lose a hypotonic fluid, you lose salt, and you lose water. So yeah, it's gonna decrease. How about serum osmolality? Not gonna decrease because of sodium, it's gonna increase because of glucose. And ICF is gonna contract. Give me an example. Diabetic ketoacidosis, hyperosmolar non-ketotic coma. What will happen when you have hyperglycemia? You will lose a hypotonic fluid. You will have extracellular fluid volume depletion when you lose fluid in the urine, leading to all of these symptoms and hyperglycemic coma, and mental status abnormalities because of the dilutional hyponatremia. How to treat this? Treat the underlying freaking diabetes. And there are specific treatments for diabetic ketoacidosis. We'll talk about this in a later video. And here is all what you need to know in a single slide. It's brilliant. Please read through it, and if you don't understand anything, let me know down below in the comments. Clinical take-home points. Diuretics make you lose a hypertonic fluid. Only the isotonic solution can correct the hypotension. If you had a car accident and you bleed, okay, EMS is gonna give you what? Blood? No, it costs them, and it's a waste of time. And they have to cross-match your blood. They give you normal saline. They will never give you a hypotonic solution. If they give you hypotonic solutions because they are stupid, the water is gonna flow into the ICF, leaving the ECF without water, leaving your body without a blood pressure. You can never maintain a blood pressure with a hypotonic solution, only an isotonic. Adult diarrhea is isotonic, infant diarrhea is hypotonic. If the patient has a brain surgery, head trauma, or a brain tumor, think central diabetes insipidus. In your exam, if the serum sodium is less than 120, answer is always SIADH. Hey, if you like this video, please consider supporting this channel on Patreon. Thank you so much in advance. Go to patreon.com/medicosis. Until next time, be safe, stay happy, and study hard.